now we discuss the ventilation practice, and I'm very proud for that because I will show you the data from the very recent study that was performed by the Proven Network investigators, and many studies are on clinical now, I will show you, are coming from this team. It's a team that was created a few years ago by some friends, and now is worldwide. Those of you who are interested to join is the provenet.eu. There's many big studies running, and you can see on the website the protocol are published in advance, very transparent, and I think we are now one of the most competitive group in the world for large clinical trials in perioperative medicine. So those of you who are interested also to be part and participate in the team, you can have a look at this website, and please feel free to ask me any information about that. And I'm very proud to show you the data from the Las Vegas trial, which was published on EGA on 2017, just 2 months ago. And this was a study supported by the European Society of Anesthesiology and within the Proven Network investigator, which is endorsed by the European Society of Anesthesiology. So our group, researcher group, is within the European Society of Anesthesiology and is endorsed by the society. And however, it's not a European group, it's a worldwide group. We have also some other people from Emirates being part, and we have also Latin America, United States, some country in Asia, and of course most in Europe, but it's becoming really a worldwide collaboration. So I will show you the data from this study. It's a very large study which included 141 centers actually in Europe, but also in South America, and some centers in the United States, enrolled more than 10,000 patients, looking at how patients are ventilated during anesthesia. This was the flow chart, and you see here at the end, we look at the more than 9,000 patients, because some patients that I will not refer are on thoracic surgery or with ventilation before surgery. So at the end, these data refer not to cardiac thoracic surgery, which are included in Las Vegas, but were excluded from this analysis. So first of all, what we use, and this is very important, a very easy score to predict those patients who develop pulmonary dysfunction after surgery. And this is the ARISCA score. Is the score which we validated on 6,000 patients on anesthesiology. So this is one of the few scores which was developed and was externally validated in another cohort of patients. So usually the studies validate within the same cohort of patients. This course was validated externally in a large population of patients. And we had got also an editorial from the editor-in-chief showing the importance of the external validation. This score applies to most of type of surgery, excluding cardiothoracic. And it's very easy. It's composed from 4 related to the patient: age, preoperative oxygenation in air, again, the respiratory infection in the last month, and preoperative anemia, which might be also associated with other comorbidities. And 3 related to the surgery, which are the emergency procedure, the surgical incision, and duration of surgery, mainly when surgery is longer than 2 hours. When this score is higher than 26, you have an increased risk, I will show you. And when with the 6 to 46, the risk is around 15 to 20%. When it's higher than 46, we have 50%. And at this level, the probability to predict is extremely high. So accuracy, sensitivity, and specificity is very high. So this is a very easy score that now we are implementing in clinical practice, and in order to define those patients who are at higher risk or not to develop PPC. And you see here that when you have a saturation in air below 92, 93, you have an extremely high percentage of patients who will develop a PPC. So very easy, just saturation in air, again, is very important. And again, this is the slide that I showed you before. So What about the population? You see that the overall population, the ARISCA score with low risk, of course, were 100%. We divided in the two groups. Around 17% of the patients, 70%, they at risk, they have a risk score higher than 44. So means that around 20% of the patients that we operate, they have a very high risk to develop PPC, okay? So it is not a small number if you consider the number of operations worldwide. So 20% of the patients, they have a high risk score among the increased risk patients, of course. They have a very high risk score. And this is the distribution on ASA classification. You see that overall, we have 35% ASA3, 4% ASA4, of course, 0.1% ASA5. So almost 38%, so almost 1/3 of the patients with ASA 3 to 4. So we are undergoing surgery, patients more and more severe. This is the first concept. This is the age you see here. Of course, the number of patients with high increased risk are older and older. And the preoperative saturation, of course, in the high-risk patients, you see that between 91 to 95, 29%, and 5% less than 90. So again, almost 30% of the patients with saturation below 95 before surgery, which is likely to develop a PPC after surgery. And preoperative anemia in 10% of patients with increased risk. This is interestingly because it's open a new issue. If you have anemic, less than 10 grams per deciliter, what should we do? So should we increase or not hemoglobin, or hemoglobin is just a reflection of severity of the patient? You know that there is now the large studies looking at the administration of iron, no, to increase hemoglobin. So what about surgery? Again, of course, in a higher percentage here, in urgent and emergency, in increased risk. Duration of surgery is longer in increased risk, and you see on average is around 200 minutes. So we are almost very fast surgery. This is important when you look at the studies. Usually you need the duration of surgery between 200 and 300 minutes, not longer. This is another important data. This is the functional dependence. And you see that in increased risk, you have almost 13, 14 patients partially or totally dependent. So we have an increased number of patients functionally dependent that they are undergoing surgery. This is something related to the quality of life after surgery that we have learned more. Now we learn a lot about more than in the past, about quality of life after ICU. We have now 2 big studies in Italy. The pilot study on tracheostomized patients, for example, in ICU, very impressive results. Almost mortality. We look at the patient tracheostomized in ICU, and then we look at the quality of life after, and we found that almost 80% of the patients died within 1 year. And the quality of life was very poor for patients and for families. So this is something that we have also a larger study in Italy, and we have many studies all over the world focusing on the quality of life. And it seems that we are creating a disabled patients in the ICU. This is a major issue. We don't know if we are creating some disabled patients also after surgery. My feeling is that we are operating more and more severe patients with more and more high technical surgery, but we have not much information what's going on. We had a discussion with our urologist just recently, and even their impression is that they are going too far in the urologic surgery. And this is something that we have to think about. But just to show our data, in low risk, 4-5%, which is not small, but in high-risk patients with Ariscat, almost 15% of patients are functional dependent before surgery. This is the chronic comorbidity. You see here, 9%, 10% in increased risk metastatic cancer, chronic inflammation, COPD, heart failure, less obstructive apnea, and so on. So again, the most common disease are cancer, kidney, COPD, and heart failure. These are the diseases that we have to take care. Surgical procedure, this was the distribution, mainly lower gastrointestinal, upper gastrointestinal, neurosurgery, urological, gynecological, and the other much bone and much less. Abdominal surgery, you see 50% of the increased risk, much higher than in the low risk. Laparoscopy, more or less, is the same. This is interesting. So laparoscopy patients are not selected according to the risk of PPC. This is something to think about. While laparoscopy is one of the best methods to reduce PPC. But we don't use the risk of PPC to select laparoscopy. So I would expect much more patients in this group. Or they are more severe and they're going to have more open surgery. Peripheral surgery is more used in low risk than in high risk. It's possible that high risk they are undergoing, of course, more severe surgery. So which type of ventilation do we use? I know that there is another lecture on the new types of ventilation. This is our data. So most of the anesthesiologists, they use volume control. Then we can agree or not, but this is the fact. Probably because we are in laparoscopy, many procedures, we want to keep a constant tidal volume. I don't know. For me, there is not much difference between but anyway, most are only 30% pressure control. Of course, very few pressure support. Others 13. So volume control is the most frequent, at least from our very recent study. Then we can discuss if it's good, not, but this is, I show you the fact. Array type, we were discussing that before. So most of anesthesiology, you see, they prefer the classical endotracheal tube, okay? And here you see the use of subaglottic device in increased risk 2, in low risk 20, you see here? So much less endotracheal, and nasotracheal almost nothing. So, as we said, the supraglottic device are used in patients with less risk of complication postoperatively, undergoing less high-risk surgery, okay? And volume control is the most frequent. Tidal volumes. Then we discuss into detail in one next lecture. So you see here the tidal volume is very fixed. You don't change between the groups. And you see this is on predicted body weight and actual body weight. You see that predicted body weight is 8 and is ranging between 7 to 9. I would like to see more and more towards 7. Okay? This is a quite large difference, less than in the past. But you see that if you target on actual body weight, is much less, of course. So which is the message that we will discuss? We should target tidal volume on predicted or ideal body weight, not on actual body weight. You have at least 2 milliliters per kilogram higher when you set on actual body weight as compared to predicted body weight, okay? PEEP, more or less, is within 5 centimeters of water. We don't use high PEEP in anesthesia. And you will see, I agree on that in most of patients. Then I don't know obesity with them. But in most of patients, this I think is excellent. I don't like to match this. We should be even a bit more conservative, but this is good. What about respiratory rate? It's very fixed. We don't look at the respiratory rate. This is not good because we tend to hyperventilate our patients. So we just fix the respiratory rate at 12. On the fix of the machine, we don't set anymore. Plateau pressure, you see, is higher in the increased risk, lower in the low risk. It's a quite large range. This is also during laparoscopy, so we have to accept a few centimeters water higher. Remember, not exceed 17 to 20 centimeters of water plateau pressure even during laparoscopy. But I will show you exactly the clinical effects of plateau pressure in my next lecture. Driving pressure, you see, is around 13 centimeters of water, including laparoscopy and non-laparoscopy. And this is on the threshold, because we found that 13 is the threshold to predict those patients who develop PPC or not. So we don't look at the driving pressure, and we tend to have high. Why that? Because tidal volume is relatively higher. So driving pressure is higher because we are using a little bit higher tidal volume, okay? Well, we should use lower tidal volume, and eventually, if you have CO2 problem, even during laparoscopy, to increase the respiratory rate. I would like to see 20 respiratory rate per minute, if needed, if needed. Compliance, you see that is a local, this is the quasi-static compliance, is low. So in most of patients, compliance of the respiratory system is low, and there is not much difference between increased risk of PPC and low risk. Recruitment maneuver is used in only 8% in low PPC risk, and is used in 13% in increased PPC. So we use low PIP and no recruitment maneuver in most of patients, okay? We fix the respiratory rate. This is not good for me. Very small range, you see. We use a relatively higher tidal volume than needed. And we use too high driving pressure because we are using a little bit higher tidal volume. Remember that there is a difference of around 2 centimeters of water between actual and predicted body weight. This is the distribution of tidal volume and patients in percentage. You see that almost 40% of the patients here are ventilated with a tidal volume higher than 8 meters per kilogram either body weight. More than 40% of patients. This I don't think is good. So check at the tidal volume in your units. This is the level of PIP. Very few patients you see. Only 10–15% are ventilated with PIP higher than 5. You see here. This is the peak or plateau pressure. The difference is 2–3 centimeters of water. You see that higher than 20, almost 40% of the patients. We don't look too much at plateau pressure, while we have to look more at plateau pressure. Why plateau pressure is higher? Because tidal volume is higher, since PIP is low. And this is the driving pressure. Is impressive. You see, almost 50% of the patients have a driving pressure higher than 13 centimeters of water. So we should further reduce tidal volume, increase respiratory rate if needed, thus reducing plateau pressure and driving pressure. This is the overall from this data. Just to have a look here. This is the tidal volume in risk, low risk in green, increased risk in yellow. Look how many patients with high tidal volume and high plateau pressure. You see here, especially patients at increased risk. Why these patients, they did not reduce the tidal volume, okay? You see how many patients have high tidal volume and high plateau pressure. There are some patients with low tidal volume and high plateau pressure. These are likely patients in which some lung injury is developing, perhaps. And probably here, we should have looked at the driving pressure, which is likely to be high, and perhaps a further reduction in tidal volume and an increase in respiratory rate might be helpful. This is the driving pressure. You see here high tidal volume and how many patients with high driving pressure, independently from the risk. So we don't care about the risk of the patients. And we just ventilate with high tidal volume and high driving pressure. On the other side, you see low tidal volume and high driving pressure. These are likely patients in which a further reduction of tidal volume or, I don't know, a little bit higher level of PEEP to improve the compliance might have been helpful, or recruitment maneuver, okay? What about FiO2? We were discussing that before. You see here the most they use from 40 to 80%. You see from 40 to 60, 60% of patients. But most of patients, they don't need so much FiO2. And you see, of course, it's a bit higher in the increased risk, but even in low-risk patients, you see that almost 75%, they use very high FiO2. And probably there is no reason, because if you look at the saturation during surgery, you see that most of patients, they have a saturation higher than 96, which is more than enough. So the concept here that we are using too much FiO2 according to the need. There is absolutely no need to stay at a saturation per se around 98, 99. If you have at lower FiO2, okay, but you don't need high FiO2 to stay at such high saturation. So this is something we have to think about. Finally, end-tidal CO2, and I remember you that 1 kilopascal is 7.5 millimeters of mercury, and look at that, 4 to 49, so means that independently from the severity, we have a CO2 between 30 and 40. So we tend to increase tidal volume to keep constant the respiratory rate and to overventilate our patients. That's why we have space for further reduction in tidal volume and driving pressure and plateau pressure, even during laparoscopy surgery. So, wow, we are in laparoscopy. Who cares? We have this data clearly showing that even with relatively protected tidal volume, we have no problem in CO2 in most of patients during laparoscopy procedures. So I think these data are very interesting to look at how we are ventilating our patients and what we could do that more. So this is what happens during surgery. Any desaturation is around 5%. So only 5% of the patients they have further desaturation during surgery, but we are using very high level of FiO2. Unplanned recruitment maneuver is higher in increased risk, but again in around 3%. Expiratory flow limitation, this is not, you see, a major issue, not much problems in terms of auto-PEEP. Hypotension is the most important. Vasoactive drug is most important, especially in patients at increased risk, you see? So hypotension is a problem during surgery, not the saturation. So this is something that is related also on hemodynamic monitoring in high-risk patients. And look at that, if you use ARISCAT score, you have at least 35% of patients, because these are patients with ARISCAT score higher than 26. These are patients likely to have, at least in 1/3, hemodynamic events during surgery. So this score, in my opinion, in our opinion, is also helpful to stratify those patients who probably they need some hemodynamic monitoring more careful hemodynamic monitoring during surgery. So patient outcome, pulmonary complication, you see 20% in patients with increased risk and 7% in patients with low risk. So it's a big numbers, big numbers. And this is the differentiation. And you see that only the unplanned supplemental oxygen was more frequent to increase the PPC. And I will show you later that even if you need oxygen, unplanned oxygen, after surgery, the risk to stay in the hospital is much longer. So, and this is the postoperative outcome. You see the length of hospital stay is a median. It's 4 times longer in the increased risk patients. Hospital mortality is much higher, 2%, and hospital-free days are almost the same. So this is just to show you that this is the distribution of PPC with time in the first 5 days postoperative in low-risk PPC or increased-risk PPC. You see that you have a progression risk to develop PPC. So sometimes people ask me, which is the time after surgery you are higher risk to develop PPC? Don't care. It's the first 5 days. You have to pay something every day. So within the first 5 days, you have a risk. Of course, the highest risk is within the first 2 days, and then you progressively increase. So this means here that likely in high-risk patients, you should have a monitoring of these patients in the PACU or high monitor environment, at least for 24 hours, 24, 48 hours maximum, okay? And in this first period here. So the first 2 days, and then you have a risk, but it's decreased, okay? This is the probability of hospital discharge. You see much slower in the patient at risk as compared to patient not at risk. But you see that at 5 days, you have always 70% here, 55% in patient in the hospital, in the high risk, and 30% in patient not at risk. And this is the mortality. You see 20% mortality in the patient at risk at 28 days. 20% mortality in patient at risk. This is the hospital mortality, 20% mortality. So with the ARISCA score, you select a patient at very high risk to die at 30 days. And if you look at the first 5 days, you see there is no difference. So if you have the anesthesiologist going in the ward, you will recognize anything. We just look at that because we monitored the outcome of the patient for 30 days after surgery. So this means that probably we should go towards what I call a sort of follow-up ambulatories for activities in intensive care and perioperative medicine. It's much more complicated we believed before. You die, you see, after the 10 days. After the 10 days, you start to open. When you don't see anymore, no, we are not involved in much in this phase. So these are the risk factors. I'm going to finish for PPC and outcome, general PPC, the age, the ASA, obstructive sleep apnea. We discussed that before. Very high risk factor for PPC. Of course, urgency and emergency. So if you have a patient with OSA, probably this patient has to be. But I can say more that these patients, if they have usually saturation less than 95, you have the ARISCA score and you identify these patients. And this is the SpO2 before surgery, which was significantly independent factor. What about severe PPC? So these are really very severe PPC. Again, the risk factor were the peak pressure or plateau pressure. Metastatic cancer, again, obstructive sleep apnea. Obstructive sleep apnea is something that we have to take in account, urgency and emergency. And you see laparoscopic was associated with a better outcome in terms of severe PPC, better prediction. Duration of surgery and duration of anesthesia in this case was not significant. SpO2, again, was very important. So SpO2 and sleep apnea and cancer and age, more or less, are the most important factor, and transfusion. So this is just to conclude here. You see here, divided in the different categories, ARISCAT less than 26, between 26 and 44, higher than 44. You see, higher than 44, the probability of PPC at 5 days is almost 35%, very high, very high. If ARISCAT is less than 26, it's much lower. However, always 7%. This is the probability of hospital discharge. You see there is not much difference in hospital discharge between when you have ARISCAT higher than 26, okay? It's the big difference is below 26 and higher. And this is the mortality, again, the main difference is when you have the worse ARISCAT, you have probability of hospital mortality was higher in the group with higher ARISCAT. I want to conclude something about obese patients. This is the Las Vegas obesity. So we selected a group of patients with obesity, with higher and lower. And you see that the probability to develop PPC is much higher in obese patients and also respiratory failure. This is the probability to develop PPC. And you see that the group at higher risk is the group with BMI higher than 40. So if we can discriminate obese patients in terms of risk, is BMI higher than 40. Below 40 are very similar. Between 30 to 40, the risk is very similar. And you see again that is the first 2 days here, but then it's progressively anyway increasing with time. So 40 of BMI is important. How do we ventilate obese patients? In red is the distribution of BMI less than 35 and higher than 35. This is the tidal volume per kilogram, predicted body weight. This is a percent of patients. You see that many obese patients are ventilated with very high tidal volume, very high tidal volume. We tend to use a high tidal volume predicted body weight as compared to normal subject. And look at that. This is the tidal volume per ideal body weight in blue. And this is the different class of obesity. You see that increasing the class of obesity, increasing tidal volume per predicted body weight, up to 10, but you see up to 15, very high tidal volume. We over-ventilate obese patients. This is not good. This is not good. We have to reduce the ventilation in obese patients. Recruitment maneuver, even in obese patients, is only, but anyway, is higher than in normal subjects, around 20%. This is the plateau pressure in obese patients. You see that in obese patients, plateau higher than 16, 17 was associated with increased risk to develop PPC as compared to obese patients with a relatively lower plateau pressure. And this is interesting. This is the distribution of proportion of patients discharged. And in this black line are the patients without PPC. In the other two are the patients who developed severe PPC or unplanned O2. What does it mean? That it's enough that you are desaturating after surgery and you give some oxygen, and the risk to stay in the hospital is the same that when you develop more severe PPC. So you have not to underestimate the minor desaturation below 95 after surgery for the reason that I showed you before. you are likely to develop atelectasis. At this point, does not make any much difference. Of course, we don't know if this is a marker of atelectasis or we are inappropriately using oxygenation, but these were patients without any an unplanned use of oxygen. So, and these are something that for us was impressive. We have some discussion now with reviewers. Just focusing here, these are obese patients, are more than 2,000 patients, you see. This is the risk to develop PPC in less severe, more severe and less severe. And non-recruited patients. These are patients, obese patients recruited by the ventilator. You see not much difference. But those patients who were recruited by bag squeezing, they higher risk, this is an association, this is not randomized, to develop PPC. So we will discuss when we discuss recruitment maneuver, but this just showing you that if you perform recruitment maneuver, especially in obese patients, there is an association between bag squeezing and complication as compared to recruitment performed by the ventilator. These are the risk factors for PPC in obese patients. We did not find any effect of tidal volume, also because the range probably was not large enough, but no effect. We found an effect of peak pressure. PEEP, interestingly, lower PEEP was associated with less risk, higher PEEP with higher risk. Now we have a large randomized trial that I will show you later. And this is a pro-based trial going to finish more than 2,000 patients randomized. We have 100 patients to finish the study, and we have higher PEEP versus lower PEEP with definite response on PEEP in obese patients. Then desaturation during surgery was associated with 4 increased risk. So if you have desaturation during surgery, probably this patient has to be admitted to a monitoring area after surgery, because it's but look at that. Postoperative residual curarization 24 times. 24 times. So this means to me that we should absolutely monitoring muscle functioning during anesthesia after recovery, especially in patients at risk and in obese patients. This is extremely, extremely important. So to conclude our study, the incidence of patients of high risk is high. A large proportion of patients received high tidal volume, a relatively low PEEP, independently from the risk of PPC. Patients at increased risk most frequently develop PPC and have a longer length of hospital stay and increased in hospital mortality, up to 30% in more severe group. And these findings suggest that more attention could be given to the lung protective modes during intraoperative mechanical ventilation in patients at risk of PPC. And this was the commentary of our study. Postoperative permanent complication, still room for improvement, and I hope that these days together we can really discuss on how to improve outcome in our patients. Thank you so much.